Question 49, which of the following challenge test findings would confirm her suspected diagnosis? So just looking at the answer choices, we have a bunch of PFT findings. So we're talking about respiratory. And if you know what a challenge test is, they're probably talking about, oh, look at this, methacholine challenge test. So you probably don't even need to read the rest. You probably just assume it's asthma, but let's just go ahead and read it. 17-year-old girl has difficulty breathing during soccer practice, especially in the cold, and she denies chronic cough or wheezing at night. Baseline spirometry is normal. And then we give her a methacholine challenge. Yep. So this is exercise asthma, frequently exacerbated by cold temperature. So now this is just a simple matter of making sure you understand pulmonary function testing. Let's get started. Let's skip A because this has two variables as opposed to all the others, which are just one. Let's start by talking about what asthma is. It's always really important to know what type of lung disease you're dealing with. And when we think of lung diseases, they're classically obstructive or restrictive. The mechanism of asthma is bronchoconstriction, narrowed airways. So asthma is an obstructive disease because we can't get the air out through the narrowed airways. A restrictive lung disease would be something like interstitial lung disease, pneumoconiosis, hypersensitivity pneumonitis, something that is essentially compressing your alveoli. Great. This was from a previous question, but right here, this represents what our bronchi look like during an asthma attack. They're narrowed during asthma attack or with chronic bronchitis, something that causes stenosis of the airways. Air just can't flow through as well, and that's typically you'll hear that as wheezing. This represents an interstitial lung disease where there's a lot of collagen, fibrous tissue around the alveoli that's really applying this compressive force to them. And this can show up as crackles on inspiration. The airways, the alveoli will just pop open, and that's the crackling sound. Restrictive lung diseases have trouble with inspiration because of this compressive force on the alveoli. Obstructive lung diseases have trouble getting air out, so with expiration. So what is the methacholine challenge test? Even if you're not sure, try to sound it out. Methacholine kind of sounds like acetylcholine. So it is safe to assume that methacholine is an acetylcholine agonist. It agonizes muscarinic receptors, including those in the lungs. And if it's agonizing the muscarinic receptors on the bronchi, that's going to cause bronchoconstriction, especially in people with particularly sensitive bronchi. So people with asthma who are already hypersensitive to bronchoconstriction, giving methacholine will make it much worse temporarily. So let's start here at the bottom. FVC, force vital capacity, decreased by 30% with more bronchoconstriction. So forced vital capacity is the total amount of air you can exhale in a single breath. There's no time component to it. And that's the difference between FVC and FEV1. Forced expiratory volume in 1 second is how much air you can breathe out in 1 second. FVC is the total amount of air. So if you had an obstructive lung disease preventing you from getting air out, then yeah, technically your FVC probably would decrease a little. So let's keep this one for now. I'm not going to cross that one off. Let's keep going here. 30% reduction in RV, residual volume. Residual volume is whatever air is left over in the lungs after you finish expiration. There's always air stuck in your lungs after you expire, and that's what your RV is. So here we're saying there would be 30% less residual volume, or in other words, you would be getting rid of more air with basically worsened asthma. That doesn't make sense. Again, this is air trapping. If anything, we would have more residual volume. 20% increase in FEV1 or forced expiratory volume in 1 second. So this is saying we would have more air. We'd be able to get rid of more air in 1 second of exhalation, which again, not going to happen in obstructive disease where the problem is getting air out. So if anything, this would be decreased, and that's what B is, right? It's the exact opposite. So B definitely makes sense. You would have a reduction in the amount of air that you can get out. Now we're thinking, okay, well, what's the difference between B and E? We'll come back to that. Let's get through A and see if that's an even better option. 30% increase in FEV1 to FVC ratio. So the ratios come up a lot in test questions. In order to get through these ratio questions, you need to make sure you understand FEV1 and FVC. And then it's just a little math. You stack them on top of each other and see what you get. So if you had increased ratio, that would mean either more FEV1 and or less FVC, just simply speaking in terms of mathematics. So let's think about it. Does more FEV1 make sense? No, we crossed that answer choice out. What about less FVC? Sure, technically that makes sense, right? We thought about E happening, but this would have to decrease quite a lot to get a 30% increase, assuming your FEV1 isn't increasing at all, which it wouldn't. It would decrease. So what's actually happening here is FEV1 is decreasing and FVC is decreasing. So if anything, this might be neutral, but it depends on which one's decreasing more. So I'm going to cross this one off because it just doesn't make sense. We would expect decreased FEV1, so probably not too much change in our total ratio. But again, it depends on which one's decreasing more. So now let's talk about that. Which one is decreasing more? Because we're between B and E now. So the problem with obstructive lung disease tends to be that you have a harder time getting air out quickly than you do getting air out in general. If you've ever heard of the term pink puffers and blue bloaters when referring to COPD, I want to talk about what pink puffer means. These people are usually fairly thin with emphysema. It's an obstructive lung disease, and they purse their lips so that they can breathe out for longer. And by exhaling for longer, they can actually get more air out. The problem is they can't get a lot of air out quickly, but they can get most of their normal FVC out just by pursing their lips and breathing for longer. So the problem with obstructive lung disease is going to be choice B. It's the rate at which you can exhale, not as much the total amount that you can exhale, although that would be affected too. And so that's why, before you click off this video, that's why in these ratio questions, in obstructive lung disease versus restrictive, you tend to see on obstructive side, we get less than 70% in our ratio, tends to be obstructive, versus for restrictive, it tends to be greater than 80%. These are good numbers just to have in the back of your mind whenever you see these types of respiratory questions, because they can help you get the answer very quickly. Less than 70, obstructive. Greater than 80, restrictive. The reason why restrictive is over 80 is because FEV1 does not decrease nearly as much in restrictive as it does in obstructive. Again, if you have that compression of the alveoli by interstitial fibrosis, collagen, you can think of it as kind of helping you exhale. It hurts with the inhalation though. So because you can't get very much air in, you can't get very much air out. So the ratio on the restrictive side looks something like this. Greatly decreased denominator, not as decreased numerator, therefore tends to be a higher number. Versus on the obstructive side, it's the opposite. You have greatly decreased ability to exhale quickly and not as decreased ability to exhale in total. So that's why the correct answer is B, decrease in FEV1.